Welcome to this explainer on a definitive, updated approach to managing adult septic arthritis in the emergency department. If you're an EP, you already know exactly what's on the line here. A bacterial infection in a joint space is basically a ticking time bomb for cartilage. 3 days. That's all it takes for irreversible destruction. So the clock literally starts the second that patient registers. Today, we're going to equip you with the absolute cutting-edge clinical workflow, straight from the 2024, 2025, and 2026 guidelines.
So picture this. It's 3 a.m., the department is a complete disaster, and you're staring at a massively swollen red knee in a 65-year-old with a known heavy history of severe gout. Is it just another standard flare, or is there a joint-destroying infection hiding underneath? It is the classic ED dilemma that keeps us all up at night, right? Well, today, we're going to arm you with the exact, up-to-date data you need to make that call with absolute confidence.
All right, Section 1, the septic joint emergency. Let's walk the exact clinical pathway you take on shift, starting right from your initial suspicion.
According to the CIMC 2024 guidelines, any acute arthritis has to be treated as infectious until proven otherwise. And listen, whatever you do not rely on a fever to guide you. Actually, scratch that. Relying on a fever will straight up lead you astray, especially because states of immunosuppression completely mask the systemic inflammatory signs we usually look for. Instead, your radar needs to spike if you see acute monoarticular or polyarticular involvement, 2 or 3 joints. And that suspicion should absolutely skyrocket if the patient has inflammatory joint diseases like rheumatoid arthritis, persistent bacteremia, or any level of immunosuppression.
Moving right along to Section 2, diagnostics and the aspiration. Let's break down the immediate diagnostic moves you have to make.
When looking at the diagnostic algorithm, the big pivot point is early closed needle aspiration or ultrasound-guided synovial fluid extraction. The absolute second you spot that effusion, securing that fluid is priority number 1. If it isn't completely obvious clinically, go grab the bedside ultrasound to locate it. Getting your hands on this fluid is still, without a doubt, the gold standard for your diagnosis.
But here's the catch. Your order of operations has to be incredibly precise. It goes like this. Draw at least 2 sets of blood cultures, do the arthrocentesis, and then push your empiric IV antibiotics. Draw the blood, secure the tap, push the meds. This specific sequence, it's non-negotiable. You can't let broad-spectrum antibiotics nuke your diagnostic yield, but at the exact same time, you can't stall treatment waiting for a perfect setup.
And please do not skip those blood cultures to get the antibiotics in faster. Why? Because studies show up to 50% of septic arthritis patients yield positive blood cultures. Since this bug usually travels through the blood, those aerobic and anaerobic cultures are vital. Here's a crazy stat for you. Synovial fluid cultures actually come back completely negative in about 20% of cases. So for 1 in 5 patients, that blood culture you drew is quite literally the only way you're going to catch the pathogen and save their joint.
All right, Section 3, rethinking cell count thresholds. This is where things get really interesting, because recent data completely shatters a clinical dogma we've relied on for decades.
We have all been drilled with the classic threshold, right? 50,000 white blood cells per millimeter cubed to definitively rule in a septic joint. It is the sacred cow of joint aspiration. Think about how deeply ingrained this magic number is in our board exams, our textbooks, our muscle memory. But treating this 50,000 mark as an absolute rule in today's ED, it's not just outdated, it can actually be super dangerous for your patients.
Here is the real game changer. Brand new 2026 data from the Journal of Bone and Joint Infection reveals that a much lower threshold, specifically 20,000 cells combined with greater than 70% PMNs, is incredibly safer and way more accurate for certain vulnerable patients. The combination of those 2 specific data points is key. Researchers looked at patients with borderline counts and found highly destructive culture-positive infections hiding way below that 50K mark. If we stick blindly to the old dogma, we are going to miss things. Period.
So who are these vulnerable patients? Well, if your patient has a prior history of a septic joint, inflammatory arthritis like RA, or a crystalline arthropathy like gout or pseudogout, the old 50,000 cell rule is a complete trap. Why? Because these folks have a chronically altered local synovial environment. That baseline information basically blunts and masks the massive white count spike you'd normally expect in a virgin joint. So for patients with these specific comorbidities, you absolutely must drop your diagnostic threshold down to that 20,000 cell mark.
Which brings us to Section 4, the 1-hour management window. Time is joint, folks, and we need to act right there in the resuscitation bay.
The massive takeaway here is the strict 1-hour protocol. You have exactly 60 minutes from the moment you suspect the infection to finish those cultures and physically have the IV antibiotics running into the patient's arm. And look, we all know the reality of a busy shift. The friction, waiting on a portable x-ray, holding for a busy resident to call you back, but the guidelines are clear. You cannot delay treatment for more than 45 minutes while waiting for exhaustive imaging or specialty consults. You've got to push through the friction because that clock is ticking for source control.
When it comes to your empiric IV options, assuming no crazy allergies, guidelines lean on IV penicillin or ampicillin as the initial drugs of choice. Third-generation cephalosporins like ceftriaxone are your really solid alternatives here. Of course, you've got to cross-reference this with your hospital-specific antibiogram and the patient's risk factors. If it's indicated, don't hesitate for a second to add robust MRSA coverage like vancomycin or linezolid. Broad, aggressive empiric coverage within that golden hour. That's the goal.
Now for Section 5, Surgical Disposition and Outcomes. The antibiotics are running, but all septic joints require definitive drainage. Let's look at how this is changing.
This is when you're calling ortho. A huge 2025 systemic review published in the American Journal of Sports Medicine looked at over 34,000 patients, comparing minimally invasive arthroscopy directly against the traditional open arthrotomy for large and intermediate joints. We've debated this for years, right? Is a scope really enough to clean out a nasty infection compared to a definitive open washout? Well, the data says yes, it's a total game changer.
The 2025 evidence proves arthroscopy is at least as effective as open surgery for those large and intermediate joints. But it gets better. It tends to favor much better functional outcomes. And get this, it's associated with hospital stays that are up to 12 days shorter. 12 days. And the reoperation rates are completely comparable, if not lower, when the scope is used. So when you're on the phone with your surgical colleague at 3 in the morning, bring this data up. It gives you the ammunition to confidently advocate for a minimally invasive washout.
Let's wrap this explainer up with Section 6, Key Takeaways for the ED. Here are the clinical essentials.
When that next hot, swollen knee rolls in, this is your mental checklist. 1. Obtain your 2 sets of blood cultures and secure the synovial fluid before you give antibiotics. 2. Hit that 1-hour window to get empiric IV antibiotics running. 3. Aggressively lower your diagnostic threshold down to 20,000 cells for your at-risk patients, like those with gout or RA. And 4. Confidently consult for arthroscopy, knowing the latest evidence strongly backs it.
So, with these updated 2026 guidelines totally rewriting the textbooks, how are you going to approach the next borderline joint aspirate that comes through your ED doors? Are you willing to let an outdated 50,000 cell count rule risk a patient's joint on your watch? Keep your thresholds low, act aggressively within that golden first hour, and protect the joint. Thanks so much for joining me for this explainer, and hey, stay sharp on your next shift.